Good morning, sir.
Can you please turn off your microphones? Okay, so today we'll be discussing about chronic pancreatitis. Okay. So chronic pancreatitis is defined as it is usually a pathological diagnosis, okay, histological diagnosis, and is defined by permanent and irreversible damage of the pancreas. Usually, the pancreatic acinar cells are damaged first. Later on, the islet cells, Langerhans cells, all these cells are damaged as a result of inflammation, which lead to fibrosis and finally gland destruction. So as I've already told you, it is generally a histological diagnosis. Okay. So in this slide, you can see the picture of a case of histological picture of a case of chronic pancreatitis, in which we can see the destroyed acinar cells, which have been replaced by fibrous tissue. Okay, extensive fibrosis can be seen, and there are some relative sparing of pancreatic cells, islet cells. Your blue color goes with pancreatic islet cells. Okay. Purple color that can be seen is the spared pancreatic islet cells, which later on obviously get destroyed. So all these factors, inflammation, fibrosis, and gland destruction, now usually are initiated by infiltration of lymphocytes, plasma cells, and macrophages as a result of inflammation. This results in ductal dilatation. There are certain areas in which the duct gets dilated, and there are certain areas in which there is stricture of the ducts. There are formation of eosinophilic plugs, and as I've already told you, islet cells are involved, but they are involved late in the course of the disease. So we'll be discussing about these later. Okay. Now let's go to the pathophysiology. There are certain theories that are brought about for the pathophysiology of chronic pancreatitis. Okay, but usually the path that leads to chronic pancreatitis is normally due to cellular necrosis and apoptosis. Okay, so the most common cause of chronic pancreatitis is chronic alcohol consumption. Okay, so in patients of chronic alcoholism, around 10% of the heavy alcohol consumers land up with chronic pancreatitis. So whenever alcohol is taken, it is converted into acetaldehyde in the liver, FAEE in the pancreas, okay, fatty acid ethanol esters in the pancreas. So this fatty acid ethanol esters, which gets accumulated in the pancreas, increases the intracellular calcium, okay, within the pancreatic acinar cells and later the islet cells as well, which results in cell injury. Also, the other theories related. One is so in patients who have chronic pancreatitis as a result of heavy alcohol consumption, one is this theory. Okay, fatty acid ethanol esters, which is convert pancreas, causes an increase in the intracellular calcium level, which causes cellular injury. Also, another theory proposed is alcohol also increases the sensitivity to CCK, cholecystokinin. Okay, and the other one is it stimulates stellate cells, which finally damage the pancreatic acinar cells and later the islet cells. The other important cause of chronic pancreatitis is hereditary, idiopathic or hereditary or tropical pancreatitis. In this, there are mutations of genes. Okay, the genes, namely PRSS1 mutation, can occur. Spink gene is thought to be mutated in certain cases of hereditary pancreatitis, whereas CFTR gene, cystic fibrosis gene, is also thought to be a cause. Mutation of CFTR gene or cystic fibrosis transmutation gene is also thought to be mutated in cases of certain cases of hereditary and tropical pancreatitis. Now coming to the etiology of chronic pancreatitis. Okay, there is a system that is usually used for the etiological classification of chronic pancreatitis, that is known as TIGARO, TIGARO. So these are mnemonics. Okay, T stands for toxic metabolites, I stands for idiopathic, G stands for genetic, A stands for autoimmune, R stands for recurrent severe acute pancreatitis, and O stands for obstructive causes. Okay, so we'll be discussing all these individually. So, in toxic metabolites such as we have already discussed, alcohol is one of the most important toxic metabolite that leads to chronic pancreatitis. Tobacco smoking has also been thought to be a risk factor for chronic pancreatitis, but mainly it is an independent risk factor for pancreatic carcinoma more than chronic pancreatitis. Okay, but it has been thought to be a cause. Hypercalcemia, for example, in patients with hyperparathyroidism who have long-standing hypercalcemia, it can lead to chronic pancreatitis. And patients with lipid disorder, dyslipidemia or hyperlipidemia, these patients are also uh, prone to have chronic pancreatitis later in their life. Idiopathic, yeah, idiopathically, the chronic pancreatitis can be divided into early onset, late onset, or tropical. And in genetic mutations, as I've already told you, PRSS1, CFTR gene, SPINK1 gene mutations are considered to be causative factors in cases of hereditary, idiopathic, or tropical chronic pancreatitis. There are certain autoimmune causes which can be divided into type 1 and type 2 causes. And recurrent means chronic pancreatitis can also occur as a result of recurrent episodes of acute severe pancreatitis. Okay, acute severe pancreatitis occurs in a patient if there is the usual causes are gallstone disease, gallstone pancreatitis, and alcohol. So if a patient consumes heavy alcohol or gets repeated attacks of acute pancreatitis as a result of gallstone disease, there will be certain changes. There will be injury to the pancreatic acinar cells, which heals by fibrosis. Okay, then there will be a recurrent attack if not treated, or if alcohol consumption is not abstained. Then there will be a recurrent attack. Then there will be again injury to the tissues. Then heals with fibrosis. Later on, the fibrotic tissue becomes more than the normal tissue, as a result of which the features of chronic pancreatitis ensues. So, in cases of certain vascular diseases or radiation therapy or post-necrotic conditions, recurrent severe acute pancreatitis can occur. And there are certain anatomical anomalies that can result in chronic pancreatitis. For example, pancreatic divism. I hope you all know what pancreas divism is. So in pancreas divism, what happens is the major pancreatic duct. There are two pancreatic ducts, right? It is the main pancreatic duct, and the other is the accessory pancreatic duct. The main pancreatic duct usually uh, delivers all the chemical compositions and hormones into the second part of the duodenum, right? Through the major duodenal papilla. And the minor accessory pancreatic duct takes only a small amount of these chemical composition, chemicals. But in cases of pancreatic division, what happens is the main pancreatic duct, which takes the bulk of the pancreatic secretions, opens into the minor duodenal papilla. Okay, so due to this, there is repeated obstruction of the flow of pancreatic secretions, as a result of which there will be episodes of acute pancreatitis or even chronic pancreatitis at times. So ductal obstruction can result in chronic pancreatitis. It can be due to retained stone in the ampulla of Vater. It can be due to a mass in the distal common bile duct or periampullary region or in the head of the pancreas. Duodenal wall cysts around the major duodenal papilla can also cause obstruction, and sometimes ductal scars due to passage of a stone and the development of fibrosis, or after procedures such as ERCP, okay, or after even after open surgical techniques, if the pancreatic ductal lumen gets strictured, then chronic pancreatitis can occur in a patient. So the most important etiological cause is alcohol, and usually, if a patient, if an individual takes more than 150 grams per day of alcohol continuously for a period of 5 days, 5 years, then in 10% of these patients, there is chances of development of chronic pancreatitis. Okay. So, or if the patient consumes alcohol for a period of 5 years in that amount, or if there is recurrent acute pancreatitis for 5 to 6 years, if the patient has multiple episodes of recurrent pancreatitis for a period of 5 to 6 years, then he has a very high chance of development of chronic pancreatitis. And these two etiological factors, if it is due to chronic alcohol consumption or if it is due to recurrent acute pancreatitis over a period of 5 to 6 years, if the patient develops chronic pancreatitis, then the prognosis of these two etiological causes is very poor. Okay. And tobacco is another risk factor, but as I've already told you, it usually increases the risk of pancreatic carcinoma more than chronic pancreatitis. Okay. So now the third important cause is tropical pancreatitis, and usually it occurs as a result of mutation in the SPINK1. As I already earlier told you, if there is mutation in the gene SPINK1 and chymotrypsinogen gene, then usually tropical pancreatitis ensues, and the mean age for tropical pancreatitis is around 24 years. And the classical clinical picture that can be seen in a patient of tropical pancreatitis is a young age. The male and female ratios are not that different. If a patient of young age comes to you with pain abdomen, with severe malnutrition and endocrine or exocrine insufficiency, then we have to suspect that the patient might have tropical chronic pancreatitis. Okay. And in this tropical pancreatitis, endocrine deficiency is almost inevitable. It will occur no matter what. Okay. And it is different from other cases of chronic pancreatitis in that in most of the cases of chronic pancreatitis, the patient will have steatorrhea. Okay, but in cases of tropical pancreatitis, the patient usually does not have steatorrhea. It is rare. So, in cases of autoimmune pancreatitis is the characteristic feature is usually lymphoplasmacytic cells with IgG4 okay, immunoglobulin G4 expression can be seen. So, in these patients, if this genetic expression immunoglobulin expression can be seen, then if we give glucocorticoid therapy, then the patient will respond rapidly. It is more common in middle-aged men, and the commonest presentation is with is that of painless obstructive jaundice. Okay, and if you do USG in autoimmune pancreatitis, you will see a diffusely enlarged pancreas, and on CT there is a specific shape of the pancreas, which is sausage shaped. And if we do a contrast study, then we can find a delayed and a prolonged enhancement of the pancreatic tissue. And if facilities are available, then you can do a serum IgG4 analysis, in which you will get an IgG4 level of more than 280 milligrams per deciliter. So if all these things are present, if there is IgG4 expression or serum IgG4 of more than 280 mg per dl, if the patient is a middle-aged man and presenting with painless obstructive jaundice, and on CT and USG you find such things. And if you give glucocorticoid therapy, then the patient, if rapidly responds, then these are suggestive of an autoimmune type of chronic pancreatitis. So there is a criteria known as HISOR criteria for autoimmune pancreatitis, in which you require histological evaluation. Okay, imaging, as I've already told you, USG and CT scan can be done to see whether there is a sausage-shaped pancreas with prolonged and delayed enhancement, and on USG you get a diffuse enlargement of the pancreas. On serology, IgG4 levels should be more than 280 mg per dl, and you can also see other organ involvement. And finally, you see response to glucocorticoid therapy. The patient rapidly improves after the glucocorticoid therapy. Obstructive chronic pancreatitis is usually caused due to tumors, as I've already discussed, periampullary tumors or tumor of the head of the pancreas. Mm, there can be scars due to stones, due to instrumentations, there can be strictures, or some anatomical conditions such as pancreas divisum, which I have already discussed. And in case of recurrent or severe acute pancreatitis, there is usually pancreatic necrosis. And if it is infected, you do a surgical debridement. So in these conditions, the patient, the chances of the patient landing up into chronic pancreatitis is very high. And if the patient has a triglyceride hyperlipidemia, if the patient has hypertriglyceridemia of more than 1000 mg per dl, then the patient is in a high risk category of having chronic pancreatitis later on in there are certain conditions in which the patient might have asymptomatic pancreatic fibrosis. Okay, as the age develops, the patient can have some asymptomatic pancreatic fibrosis. In patients with chronic renal failure, they might land up with asymptomatic pancreatic fibrosis, and those who are undergoing hemodialysis, they can also have features of asymptomatic pancreatic fibrosis, means a type of chronic pancreatitis. Okay. So, idiopathic chronic pancreatitis has two types of onset: early onset and late onset. Idiopathic chronic pancreatitis, early onset, the mean age is usually 20 years, and in late onset chronic pancreatitis, idiopathic chronic pancreatitis, the mean age is usually 55, 56 years. The gender distribution on both these early and late onset idiopathic chronic pancreatitis is almost similar. Okay. And in early onset, the predominant symptom is clinical feature is pain, whereas late onset idiopathic chronic pancreatitis, usually the patients complain with either exocrine or endocrine insufficiencies. With exocrine and endocrine insufficiencies, we will be discussing later. Okay. So the three important clinical features that define chronic pancreatitis. It is finally a histological diagnosis, I have already told you, but it has to be uh, the patient has to have certain characteristic symptomatologies, okay, in order to say that the patient is having chronic pancreatitis. The most important symptom is a chronic abdominal pain, chronic epigastric pain, which usually radiates to the back. Okay, dull aching खालको pain हुन्छ. Usually the patients have steatorrhea, and as the disease progresses and there is onset of destruction of the islet cells, then the patient will finally land up into diabetes mellitus. Now, the characteristic of the abdominal pain is usually it is epigastric, like in acute pancreatitis, but it is not that severe. It is continuous dull aching type of pain, but it is not as severe as that of acute pancreatitis. It is deep, boring, and penetrating type of pain, and is usually worsened after a meal. And the patient, classically, if the patient sits or leans forward, usually assuming a knee chest position, and then usually the pain is relieved. So if you ask a patient who comes to you with chronic abdominal pain, deep penetrating type of pain which radiates to the back, and you ask the patient to lean forward in a knee elbow position, if the pain gets relieved, then it is usually of pancreatic origin. So chronic pancreatitis my aim, right? So what are the different causes of pain in a patient of chronic pancreatitis spondylitis? Right? Due to a decrease in blood flow and due to all these tissue injuries, there is tissue ischemia. So ischemia results in pain. और due to hyperstimulation by CCK also it has to work a bit more, as a result of which there is pain. And due to this fibrous pancreatic tissue, it is a retropancreatic nerves. It starts irritating the retropancreatic nerves. Okay, and this fibrotic pancreatic tissue irritates the retropancreatic nerves, which lead to pain. So retropancreatic nerve, like fibrotic tissue, it is compressing and the pain occurs. So if you ask the patient to lean forward, okay, this pancreatic tissue that has been coming in contact with the retropancreatic nerves will go forward, as a result of which there will be the pain will decrease. There will be a decrease in the intensity of the pain. So in steatorrhea, okay, what happens is the patient will pass bulky fouls, smelling stools, or patches of frank oil droplets. Okay, that occurs usually in a patient of chronic pancreatitis. The stool has to be bulky, foul smelling, or there has to be passage of frank oil droplets. And the lipase secretion, this usually occurs when the lipase secretion, okay, one important job of the pancreas, the exocrine pancreas is to secrete lipase, okay, for fat digestion. So if the secretion of lipase goes below 10% of its maximal output, then steatorrhea usually occurs. Okay. So fat in chronic pancreatitis, fat maldigestion usually occurs earlier and is more severe compared to protein and carbohydrate maldigestion. Okay. So the reasons are lipase secretion decreases earlier. Lipase is more sensitive to acid destruction and pancreatic proteases, whereas bile salts also precipitate. Okay. So if a patient has chronic pancreatitis has symptoms of upper abdominal pain, then usually after the starting of chronic pancreatitis, this exocrine insufficiency, most commonly in the secretion of lipase and passage of bulky foul-smelling stool or fat droplets, which is also known as steatorrhea, usually occurs after 13 to within 13 to 26 years of the occurrence of these first symptoms of chronic pancreatitis. Okay, and this usually results in weight loss as well. With this, so fat soluble vitamins will obviously most importantly, vitamin D deficiency can be seen. All fat soluble vitamins will be deficient, but more importantly, vitamin D deficiency is especially seen. Now, as I've already told you, if the disease is not treated, or if it is due to tropical pancreatitis, then eventually the patient will land up into a diabetic state. Okay, so usually the mean time of development of diabetes after a patient has been diagnosed with chronic pancreatitis is lipase deficiency हुनलाई चाहिँ exocrine deficiency हुनलाई चाहिँ to 30 to 26 years, whereas diabetes हुनलाई चाहिँ 19 to 26 years लाग्छ है त. So these are certain complications of chronic pancreatitis. As I've already told you, the most common complication bhanau is symptom. Symptom can also be a chronic abdominal pain. Then, if left untreated, the patient will land up with diabetes mellitus, where insulin has to be given. Gastroparesis, malabsorption in the form of steatorrhea. Gastrointestinal bleeding. Gastrointestinal bleeding usually occurs as a result of upper gastrointestinal bleeding. Usually occurs as a result if the chronic pancreatitis is due to tumors. Okay, periambular carcinoma रहेछ, duodenal cystहरू, polypsहरू रहेछ भने त्यहाँ चाहिँ erosion भएर there can be bleeding. Cholestatic jaundice can occur if there is obstruction of the biliary flow. And if left untreated, biliary strictures ले गरेर biliary cirrhosis हुन सक्छ. And there are certain rare complications in the form of pancreatic fistula, and sometimes rarely pancreatic chronic pancreatitis can develop into pancreatic cancer as well, CA pancreas. So on the left you can see a CT in which a pseudocyst can be seen. Pancreatic pseudocyst can be seen. Okay, pancreatic pseudocyst is the commonest complication of chronic pancreatitis. Okay, the most common cause of pancreatic pseudocyst is acute pancreatitis, but the most common complication associated with chronic pancreatitis is pseudocyst, pancreatic pseudocyst. And on the right side of your screen, this is an ERCP. Okay, ERCP there is a smooth stricture. The arrow, the two arrows that are pointing are towards a stricture that is present in the bile duct. Okay. So this has resulted in distal bile duct strictures it is going down towards the ampulla fetal, as a result of which there is chronic pancreatitis. So can you please turn off your mics? So now coming to the diagnosis, okay. If the patient has symptoms consistent with chronic pancreatitis, then you have to go for tests. Okay, the test can be divided into two categories. One is test for pancreatic functions, one is test for pancreatic structure. Okay. So pancreatic function go like I said, there are two types of tests. One is a direct test, one is indirect test. In direct test, we do a direct hormonal stimulation test, which is the most sensitive test. Okay. यसमा चाहिँ mean peak bicarbonate concentration is seen, and a mean peak bicarbonate concentration of more than 80 milliequivalent per liter is considered to be normal. Okay. So if it is less than this, the patient has chronic pancreatitis. The hormonal stimulation is more sensitive and specific than ERCP. So direct hormonal stimulation test is of utmost importance, but the limitations associated with these tests include limited availability by LM, and oroduodenal tube has to be kept for an hour or more to do this procedure, which is quite cumbersome for the patient. Indirect tests, it include serum trypsinogen. The level of serum trypsinogen can be seen. If it is less than 20 nanogram per milliliter, then it is suggestive of an advanced chronic pancreatitis. Okay. Fecal elastase can be seen, in which if the fecal elastase level is less than 200 micrograms per gram of stool, then that is suggestive of the patient has some kind of exocrine insufficiency. And if fecal fat can also be seen, fecal fat or 7 hours stool collection is mandatory. Okay. Normally, less than 7% of the ingested fat is excreted in the stool. Okay, if it is more than this, then the patient has some kind of exocrine deficiency, probably chronic pancreatitis. And to be more specific, if there are more than 6 fat globules per high power field, then it is considered to be abnormal. Fat globules say stool, if they are more than 6 per high power field, then they are thought to be normal, and you have to you have to think that the patient is suffering from certain exocrine deficiency. Now these tests, direct and indirect tests, were done for to evaluate pancreatic function. Okay, the pancreatic function means direct hormonal stimulation tests are more specific and sensitive than ERCP, and it has to be done in order to prove a patient has chronic pancreatitis. Okay, यसमा गर्ने भनेको चाहिँ तिमीले mean bicarbonate concentration हेर्ने, mean peak bicarbonate concentration, the normal value of which is 80 milliequivalent per liter, but if it is less, then the patient will have chronic pancreatitis. Pancreas को एउटा काम bicarbonate secretion पनि हो नि हैन. So if it goes below 80 milliequivalent per liter, then the patient will have will usually have chronic pancreatitis. Or indirect testहरुमा चाहिँ serum trypsinogen हेर्ने, fecal fat हेर्न सकिन्छ, अनि pancreatic enzymes in stool यो हेर्न सकिन्छ. So these were for the evaluation of pancreatic functions. But now our pancreatic structure पनि change भएको छ कि छैन भन्दैलाई चाहिँ we have to see. We can do certain tests. Okay, radiological tests हरु. यसमा चाहिँ plain abdominal radiography can be done. So in plain abdominal radiography, what it is not that specific or sensitive, but you can get an idea, a gross idea about how the pancreas is. So in plain X-ray of the abdomen, you can see a diffuse pancreatic calcification can be seen. Okay. Usually it is more common in alcoholics or late onset idiopathic hereditary and tropical pancreatitis. There will be diffuse calcifications that can be seen around the area of the pancreas. Okay. On abdominal USG, you can find, as I've already told you, you go to tropical pancreatitis, sometimes you'll find a diffusely enlarged pancreas. But if the patient is old, it is quite difficult to differentiate it from age-related enlargement or due to some other causes. So the best diagnostic modality to know the structure of the pancreas is CT scan. And based on CT, grading of chronic pancreatitis can also be done. So in chronic pancreatitis, if you do CT scan, then the usual findings are ductal dilatation. Ductal dilatation, ductal narrowing, ductal strictures are. There will be multiple calcifications, multiple stones can be seen, irregular contour of the pancreas, and there will be parenchymal heterogeneity, right? The other radiological investigations that can be done for the diagnosis of chronic pancreatitis are MRI. MRI is more sensitive when you do a secretin stimulation test. Secretin stimulation, SSMRI once, secretin stimulation MRI, you inject secretin into the patient intravenously, okay? Then you take MRI pictures. So if you do it, it becomes more sensitive, okay? And finally, ERCP can also be done. ERCP is, as we all know, both diagnostic as well as therapeutic. So we can see all those abnormalities. Usually, ERCP gives you idea about all the ductal abnormalities that can occur, which can lead to chronic pancreatitis. So in this case, this is an ERCP, endoscopic retrograde pancreatography, where there is marked dilatation of the main pancreatic duct with alternating stricture and dilatation, right? You can see there is marked dilatation. This one is the marked dilatation, and there are alternating strictures and dilatation within the main pancreatic duct. So this, if you see in ERCP, is known as chain of lake appearance, and this, if you are able to see this picture in ERCP, then it is usually suggestive of chronic pancreatitis. This is known as chain of lake appearance. This upper one is the tube, okay? The lower one, which is seen to be irregular, very irregular, with areas of stricture, areas of dilatation, areas of stricture, areas of dilatation. So that is the main pancreatic duct, which is dilated. It is not normally. This is not the normal, usual size of the main pancreatic duct. Okay, if it goes beyond 7 mm or more, then it is visualized properly, and this is more than, I think, 1.5 centimeters on the body alive. And there are multiple strictures, irregulars, multiple strictures with dilatation, stricture, dilatation. So this is known as chain of lakes appearance, and this is a diagnostic feature of chronic pancreatitis. Another investigation, this is a very recent investigation that has been added, but the only drawback of this investigation is its availability. Endoscopic ultrasonography, ultrasonography can be done endoscopically, okay, but it is not available in all the institutes. So if it is present, if the facility of endoscopic ultrasonography is present, it is a very useful diagnostic modality in cases of chronic pancreatitis, and also in cases of pancreatic carcinoma. Okay, there is a criteria known as Rosemont criteria, and this is an endoscopic criteria for defining chronic pancreatitis. Okay, if the Rosemont criteria score is more than 5, then it is highly specific. Okay, if the score is between 3 to 4, then it is indeterminate. So if the abnormalities that can be seen through endoscopic USG in a case of chronic pancreatitis include those of parenchymal abnormalities and ductal abnormalities. Okay, there are 4 abnormalities that have been described under these topics. If there is presence of 3 or more of these abnormalities, be it by adding up both these, be it parenchymal or ductal. If it is three or more, then usually you can say that the patient might have chronic pancreatitis. Okay, but between 3 and 4, it is thought to be indiscriminate, indeterminate. But if it is more than 5, then it is highly likely that the patient has chronic pancreatitis. Okay, parenchymal and abnormalities include hyperechoic foci, hyperechoic strands, uh, lobularity, lobularity. The contour should be lobularity in contour, and there can be certain cysts, development of cysts, pancreatic cysts around also. Ductal abnormalities, the main duct, as I've already shown you in the ARCP picture, the main duct usually gets dilated and becomes irregular. There will be hypoechoic duct walls, and the side branches will also be visible, and there can be calcifications. Okay, so out of all these 8 criteria, if 3 or more are positive, it is thought to be pancreatitis, but it becomes the Rosemont criteria becomes highly specific if out of these 8, 5 or more criteria are met. Okay, so you have to learn this by heart because it is quite important. Okay, theories ma chai sodhna सक्छ Rosemont criteria. Now अब diagnosis कसरी गर्ने भन्दाखेरि चाहिँ मैले भने नि अघि the patient should have pain as a primary complaint, and certain other features such as steatorrhea हुन सक्छ, chronic abdominal pain, steatorrhea with presence of features of diabetes mellitus भएको पेशेन्टमा चाहिँ now you suspect the patient might have chronic pancreatitis. You go for CT. CT is the best modality अहिलेसम्मको लागि चाहिँ. If EUS is not available, then CT is considered to be best modality. So high quality multi-detector CT छ भने चाहिँ you do high quality multi-detector CT. त्यसपछि गएर यो नन डायग्नोस्टिक आयो भनेपछि चाहिँ you can do hormonal stimulation test, direct pancreatic testing गर्ने हैन. अनि त्यसबाट पनि भएन भने चाहिँ you can do EUS, ultrasonography, endoscopic ultrasonography गर्ने. Now, once you have come to a diagnosis of chronic pancreatitis, usually the final diagnosis only comes after doing a histological examination. But if these criteria are met, if the patient has symptoms that are consistent with chronic pancreatitis, such as chronic abdominal pain, with all those qualities of the pain, and if the patient has steatorrhea and patient has features of diabetes mellitus with weight loss, then you can do all these investigations. Okay, now coming to the treatment, abdominal pain is one of the most important and debilitating things that is associated with chronic pancreatitis. So the patient usually cannot get rid of that. If chronic pancreatitis has ensued, then usually the patient will have chronic upper abdominal pain, maybe for lifelong. So this has to be addressed first. Okay.
Yeah.
The conditions that can be associated with abdominal pain include pancreatic cirrhosis, duodenal bile duct compression, superimposed pancreatic cancer, or gastroparesis. Okay. So in medical therapy, you can give analgesics. Analgesics, you can give opioid analgesics, or non-steroidal anti-inflammatory drugs can also be used. Suruma, you start with non-steroidal anti-inflammatory drugs, but if they do not work, then you have to go for opioid analgesics in the form of tramadol, pethidine, morphine. If the patient is an alcohol or a tobacco consumer, then you have to ask the patient to abstain consumption of alcohol or tobacco. Antioxidants can be given. Pancreatic enzyme therapy and octreotide can have also been tried, but with less effect. Okay. So as I've already told you, NSAIDs are the first line of analgesics which can be given. If they do not act that well, then opioid analgesics have to be given. And due to this chronic pain, the patient can also have some kind of psychological effect. Okay, so in order to reduce this, you can use tricyclic antidepressants, systemic serotonin, selective serotonin reuptake inhibitors. Okay. So, and if this depression can be avoided, then the coexistent pain can also be, the pain threshold can also be lowered. Coexistent pain threshold can also be lowered. So these are certain antioxidants that can be used, which might help a patient of chronic pancreatitis to subside his or her pain. Now the next therapy is to give exogenous pancreatic enzymes. Okay. So all these exocrine insufficiencies can be managed by giving external pancreatic enzymes. So there are various products such as enteric coated preparations or non-enteric coated preparations of pancreatic enzymes. But pancreatic enzyme therapy is not usually done to relieve the patient of pain, but to relieve symptoms such as these features related to exocrine deficiencies such as steatoriaहरू जुन हुन्छ, malnutrition, malabsorptionहरू हुन्छ. So these can be avoided by giving exogenous pancreatic enzymes in the form of capsules, tablets, capsules. So you can use this. Octreotide has also been tried in the treatment of chronic pancreatitis. So it is thought to reduce pancreatic secretions and circulating cholecystokinin levels. Okay. If the patient has chronic pancreatitis as a result of a stricture or a ductal stone, then endoscopic therapy is most appropriate in the form of ERCP endoscopic retrograde cholangioppancreatography and dilatation of that stricture, sometimes stent placement, or if there is stone, then retrieval of the stone. Okay, so the options include pancreatic duct sphincterotomy. The sphincter like काट्दिने हुन सक्छ एउटा. Sometimes you might have to place a stent in the pancreatic duct, or pancreatic duct stone removal can also be done. Surgical therapy is not usually indicated, but if the patient has intractable abdominal pain and there is failure of medical therapy, then certain patients are considered for surgical management. Okay. Other indications include if other organs are also involved, if there is failure of endoscopic therapy for cirrhosis, if there are internal pancreatic fistulas, or in order to exclude malignancy. So this can be done. Okay. यसमा चाहिँ pancreatic ductal drainage can be done in order to relieve pain, or sometimes resection of there are various methods, surgical methods that can be done in patients of chronic pancreatitis. That will be a very large topic, so we'll not be discussing all those surgical procedures individually, but there are a few procedures that can be done which usually help in drainage of the pancreatic duct. Okay, so these surgeries, the main purpose of these surgeries is to not allow the pancreatic secretions to remain stagnant within the pancreatic ducts. Okay, these surgeries allow the pancreatic secretions to drain in some way, and sometimes if the pancreatic tissues are necrosed or fibrosed or get infected, then some part of this pancreatic tissue can be resected in order to relieve the pain. Okay. So pain relief is the most important management or treatment in a patient of chronic pancreatitis. Okay, if you can do it, then the patient, as long as the patient lives, then the patient will have a better quality of life. त्यसमा चाहिँ अब त्यो मेडिकेसन्सहरु युज गर्न सक्यो. सर्जिकल थेरापीमा you can drain there is some kind of obstruction, or you can resect some part of non-functioning pancreatic tissue, and certain nerve blocks can be also given. Okay, so celiac plexus block is the most commonly used. Celiac plexus approach कर you can use glucocorticoids or local anesthetic agents, or sometimes absolute alcohol can also be injected in order to relieve pain. But this method usually requires repetitive procedure. You have to repeat the procedure many times. Okay, so the outcome is quite good, but due to because of many times that you have to repeat the procedure, it is not, and the patient compliance is not that good. So the best way, if it is if the patient is improving with analgesics, then the best method to keep the patient free of pain is by the use of analgesics, okay, in the form of NSAIDs. If not, then opioid analgesics. And along with these analgesics, you can give antidepressants, okay, in the form of tricyclic antidepressants, selective serotonin reuptake inhibitors. And if these methods do not improve the patient's pain, then there are options for surgery or some nerve blocks. So, in order to decrease the maldigestion and steatorrhea, usually lipase preformed lipase tablets can be given to the patient, which usually contain 30,000 international unit of lipase. Okay, so it can be given with and postprandial of each meal. Even if meal man say we can give it with the meal and postprandial meal, and you can use along with this you can use concomitant PPI or PPI proton pump inhibitors. So these are the treatment if the patient lands up with diabetes mellitus, then insulin is usually the treatment of choice. Okay, but over vigorous diabetes control should not be done, because the patient might end up into hypoglycemia. So autoimmune pancreatitis has a better prognosis. Okay, in patients with autoimmune pancreatitis, if you start prednisolone at 40 mg per day for 4 weeks, usually the patient starts improving. And improvement under the parameters that you need to follow are symptomatic relief. The pain will be relieved. Serial changes in pancreatic and bile ducts on imaging can be seen. There will be a reduced serum gamma globulin and IgG4. Immunoglobulin G4 levels may say reduction between. So okay, because if it was more than 280 mg per dl initially, then it will go down beyond this point after the use of prednisone 40 mg per day for 4 weeks. And there will be improvement in liver function tests also. Okay. So, and if the patient, all these criteria are not met and the patient does not improve with glucocorticoids within 2 to 4 weeks of their use, it generally tells you that the patient might have pancreatic cancer or certain other causes of chronic pancreatitis. So that's it. Thank you.
Thank you, sir.
Sir.